Thank you all for joining our fourth coffee chat. We're pleased to welcome Nichole Lilley from Houston Methodist to this call. Within operations around denials specifically, what are you hearing? Where are the pain points? What are you looking to see improvements on a technology front, on a workflow front, maybe resources front? Maybe you could give us a little bit.
So our revenue cycle team, we meet once a quarter. But even before that, each of our locations works really hard to look at our denials. The patient access directors are responsible for a specific set of denials. So we look at those initial denials, those things that come just from the insurance company processing a claim, creating that adjudication, and whatever initial denial they happen to come up with, making sure that we're going through the appeal process if necessary. Communicating back with our billing office to say, nope, that's incorrect. Here's our authorization, send this back to them. So those are being worked on a daily basis by each one of our locations in Houston Methodist. And the other piece that we really pay attention to are those final denials. And that's kind of it's an end of the road. All appeals have been exhausted, and we are just taking the hit on whatever that authorization denial is, whether we agree or disagree with it. It is kind of what it is at that point. And then we also pay really close attention to our outpatient medical necessity. Now, the patient access directors are focusing on those three types of denials. Our case management team focuses on inpatient medical necessity denials. And then, our billing office is looking at any timely filing denials. And so everybody's kind of got their own piece in revenue cycle so that it's more of a divide and conquer, hey, what are you seeing kind of situation. When talking about that focus and what we're seeing, we are seeing lots of challenges as it comes to, well, just our normal types of things, those insurance payer denials where you did all of the due diligence up front. You asked all of the questions that are necessary to make sure that you have crossed all your T's and dotted all your I's, and then you still come back with the denial. The type of downstream things that happen, obviously there's a financial impact to the facilities when we're not getting paid for things that we're doing. The procedures that we do are not inexpensive. We have, very expensive toys, if you want to say that. And so all of those things go into the services that we provide, and we like to make sure that we're providing cutting edge, all of those types of things. But over and above those types of downstream, it also affects the patient because they're getting a letter from their insurance company after they've had the surgical service saying, hey, it's not authorized, or this is going to be denied, and you potentially may owe all of this money. And so that's patient dissatisfier. It's a stressor. They're trying to recover and recoup from surgery. And some of these surgeries could have been life-saving surgeries. It could have been all kinds of things. And so it's just added stress onto our patients that doesn't need to be there when we really did do all of the things that we needed to do on the front end. And then you've got a little bit of, hey, I decided to use this instead of this. And so we're looking at add-on codes for implants and things that weren't necessarily anticipated. And quite honestly, I think from the perspective of my insurance verification team and my pre-auth team and just the leaders, as we talk about these denials on a monthly basis, you feel like you're chasing your tail a little bit because you've done all the things, you've put in all of the work, and then you've got to go put in additional work on the back end to make sure that you can capture that revenue.
So I start talking to, leaders like you in the health system, just trying to find out like, hey, what's happening? What are you struggling with? Are these things real to your health system? And the things that you mentioned are things that I hear on a daily basis with health systems all over the country. One of the things is, and I was just at HFMA last week in the Florida Section 5, and it's like, payer dynamics, like all these payer rules, and they've changed so much. And we know as a company that we have a mechanism to stay ahead of those, because that matters for who is, able to be retro auth, who is able to, who can we capture, and what revenue can we capture when you're talking about these mismatch denials. When these surgeries happen, you mentioned it too, some of these things you have expensive tools, you have life-saving procedures going on. What happens with those, typically with those authorizations, is the things that were authorized were not the most complex, right? Because you're going in thinking it's a simple procedure. Turns out to be medically necessary or more complex is actually probably a bigger ticket item too to the health system. So all of these things are I just like to point that out. Things that I hear when I start to initially speak with people, things that we can put in place as we go through the process, things that we can help with. It's all, it's a big effort, but we're all working together to solve kind of for that same problem.
For sure. And I think too, like one of the things I didn't mention was that partnership with the physician office and helping them understand the needs, not only for looking at the patient as a whole, because when they're looking at authorizing a surgical service, they know what their physician is doing. But they might not be adding those HCPCS codes that the physician's going to use for that allo matrix, or those rods and screws and plates and all of those things. And so it's a partnership for my pre-auth team to be able to go back to them and say like, hey, your physician has requested, all of these equipment and things that need to be authorized as well. We need you to add this to the authorization so that we can be covered in the hospital. And it's having those conversations with them and explaining to them the importance of, well, that's not going on my bill. I don't need the authorization, but your patient does. And we're here to take care of the patient. And so having those conversations are some of the things that we've started to do with our physician organization here at the Woodlands campus. And I know some of the other campuses across the system are starting to have those conversations to say like, hey, help us help your patient. I understand that it is an administrative burden to go back and add things to an authorization. But we do need to do it in order to make sure that we're not having a big surprise for your patient at the end. We have done some really strange things in order to combat these. We take each root cause that we do, we track it and trend it over the course of the year. We take everything back to our insurance team and say, okay, we found this denial. We found this situation where the insurance company is saying this diagnosis code does not match this procedure. You guys need to watch out for that. And so giving them as many tips and tricks as we can in order for them to be a little bit more cognizant and maybe ask a different type of question. They have a list of things that required in order for that patient's service to be covered. And you could have an authorization, but if you don't have everything checked off on that list, your authorization doesn't matter because it didn't meet medical necessity and it's still going to be denied. So it's just really trying to keep our team as informed as possible. We have created work queues for mismatches to fall in so that they could work them after the fact. We have somebody that's pulling implant reports every day after surgical services happen from the prior day to see where we can go and try to go add. Like, hey, we use this allo matrix. Please add this to the authorization that was already on file for the surgery. So there's lots of things that we've done, as you'd say, to create a mousetrap for those types of things, just for denial prevention and to make sure that we're capturing the revenue that's due to us for the services we provided. It is very difficult to manage some of these things with insurance companies, and they all have different rules. And we have to figure out what rules they're following today and make sure that we're following them.
So can I ask, I would love to go back a little bit to the root cause, but and the analysis that you do, because it sounds like for your root cause analysis, you're really taking into account what happened, what was done before, during the procedure, after the procedure, how does it impact the patient? It seems like there are many different teams involved. How are you finding that technology has changed your processes and workflows over the past few years? There's been a lot of different articles about AI. We had a coffee chat around AI governance as a new step within the sales process within hospitals, because everyone is sort of aware of the boundaries of, PHI and AI and how does it all come together. But I'm wondering if you could give us a little bit of how technology has entered this very complex system that you work within.
So I think we've got, well, Houston Methodist, we have a whole Center for Innovation, and their entire mission is to figure out how they can make us cutting edge, how can we can do more and do better for our patients, where we can leverage technology. And so you'll find that Houston Methodist does try to do as much as they possibly can in the way of automation within the
Hmm.
system, and trying to see where we can, I won't say, we'll just say leverage technology. And
Yeah.
it's done in all aspects of revenue cycles. So from the point of scheduling and decision trees and making sure that we're asking all of the important questions, right?
Hmm.
That goes there. And then that's driving whether we're scheduling this or we need to make sure that we have, something else done first. So that's happening kind of on that physician organization side to make sure that we're meeting those requirements. Um, Having NCDs that are loaded into the system so that whenever we're scheduling
Wait,
something,
NCDs.
a national coverage determination.
Okay.
So like something that would spark maybe for a Medicare patient an advanced beneficiary notification to say, hey, Medicare might not cover this because of the diagnosis that you're using. So leveraging that technology so that the physician doesn't have to memorize every single diagnosis code that covers this type of test that they want to run. And so that's, I feel, is very helpful because then at that point they can stop the conversation with the patient. It automatically flags them and says, like, hey, this is potentially not going to be covered. You need to look at your diagnosis. And then they can look at the chart. Is something better? Is there something that's going to, that better describes why we want to do this, rather than using maybe a generic code?
Hmm.
And so there's technology there. There's technology when it comes to authorization. If there's something that doesn't require authorization, we know it doesn't hit anything. Like the benefits get verified, everything goes, no one's touching it, so that we
Yep.
can spend time on the things that do require that tender touch. Um, Help with those types of things. Our RTE platforms, our real-time eligibility, making sure all of those things are coming in and that we've got that information that's being provided to the team so they know where to go, what questions to ask. Um, I would say even further down with our HIM team, after the procedure has happened and they're doing coding, I know that they utilize different platforms to make sure that coding is being done correctly. We've got audit tools and all these types of things. So everybody's doing the most that they can in the way of leveraging technology. I would
Hmm.
say that Houston Methodist, in the way of AI, they are very, very conservative. And I will say that with like my whole heart. And that is because they want to protect the patient. Like we don't
Yeah.
want to put any information out into the world that, is their personal information. So we take that very, very seriously. And so they are very careful when it comes to AI, but we do utilize it in certain areas. And so I am excited for where we can continue to like just leverage technology in this type of atmosphere, because if we could figure out a way to utilize AI in the way of denial prevention, how can we get this information back quicker? How can we react quicker? It does have the ability to make a financial impact for our facility. It has the ability to take time off of things that they're doing very manually for the team that they could be focusing on something else. It has the
Yeah.
ability to take that burden off of the patient and the worry that comes after the fact, because everybody has been burned somewhere with a medical bill. Everybody has. And so everybody's worried about it. And when you're talking about having a heart procedure or a total joint replacement or anything that is going to change the way your life is, the last thing you want to worry about is it going to be covered by my insurance? And we still have individuals who feel like, everything should be covered by insurance. Like I have insurance. Why am I paying anything?
Right.
But it's even more scary when they get that bill in the mail and they see, oh, your insurance didn't cover anything and you could be responsible for up to this amount. And it's not a small number, it's a very large number. And
Hmm.
that's a whole nother conversation about managed care and all of those things. But yeah, it's leveraging technology is something that I think we do really well. I am excited to see what we do more in the realm of AI because there are some things out there, but I just feel like with healthcare, we have to be really, really careful.
Yeah. Yeah, for sure. One of the conversations that we had around the focus of the AI discussion that we did have was around governance as another layer within the process because hospitals are concerned. But I like your approach and angle where you mentioned that Houston Methodist has been bringing in technology in all the different spaces in that incremental way so that it can remove a roadblock or help make something a little bit more efficient. And yeah, I mean, hopefully, we can leverage all of that together and make things just less stop start and more smooth within the process from scheduling through procedure and into recovery for the patient.
Yeah. I was just going to say, I think if we, and Nichole kind of hit on that too, if we all work together, like you said, we work closely with the physicians, if we all collaborate together, right, we all have the right goal in mind that we're here to help, facilitate better care and better outcomes for our patients. And we all are communicative and collaborative. We can get some really, really good outcomes and advance in technology in a very good way, in a healthy, productive way for the better of the patient.
Yeah.